Today you will learn that there's an easy tool called PenFast that you can use to delabel a patient who has an inappropriate penicillin allergy. Easy, applicable, yes, you can do it. Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana. Welcome back to EM Pulse.
We are back with another Push Dose Pearls with our trusted ED pharmacist, Haley Burhans. She's an emergency medicine clinical pharmacist at UC Davis.
Haley, one of the things that drives me bonkers is how often I see patients with penicillin allergies. And then when I ask them about it, they say they had diarrhea with Augmentin. So I can't even say that without laughing. Or a rash, or worse. Okay, this one really drives me nuts, is that they say that they put it on as an allergy because their parent was allergic. And so they put it in there too, assuming that they were going to be allergic. And actually, the data backs this up, my own frustrations. Penicillin is one of the most commonly reported drug allergies, yet studies indicate that up to 90% of individuals labeled as allergic may not have a true allergy. Let's just say it out loud. Besides making me bonkers, what are the downsides of inappropriate penicillin allergy labeling?
Yeah, so there's actually a very long list of downsides published in literature. So to kind of make them succinct, I think the biggest thing for us to keep in mind and provide some education to patients is treatment failure, right? So if I'm avoiding a whole class of medications because of your allergy, then I may choose an antibiotic that's less optimal for you and the infection that you present with, which may mean that you come back because that infection is persisting. Or we have to give you something that has worse side effects, and now we're having to manage those side effects. There's actually data supporting that there's increased mortality. Again, I think this is likely secondary to delays in antibiotic administration that's documented in the literature, because now we're having to figure out, if we can't give you kind of these first and second line recommendations, then what's our third line recommendation? And is that compatible with this allergy? And we're having to go down all of these questions to make sure we're getting you appropriate therapy. We're also increasing resistant bacterial infections like MRSA and VRE because we end up avoiding penicillins and giving everyone vancomycin for skin soft tissue infections. So not only are we potentially doing a disservice to that patient, but to our community and people that have infections in the future, which is always alarming. And then for some of these antibiotic classes, they're really high risk for C. diff infections. So penicillin and beta-lactams are correlated with C. diff infections, but secondary, when we avoid these, we often give people things like clindamycin or fluoroquinolone, which have really high rates of C. diff infections. And then you're talking about they may require 2 antibiotics because we're trying to avoid this class. So, there's a lot of things that we're doing as a disservice to that patient themselves, but also to kind of our community keep in mind when we're honoring these penicillin allergies that may or may not truly affect the patient's health if they've seen that drug.
Yeah, our community and how much it costs to be a patient in our system, because you have more bounce backs and you have more admission rates because some of these alternatives are only available via IV. It is very real.
So how can we tell if a patient is truly allergic to penicillin?
Yeah, so I think, to Julia's point earlier, a lot of times, obviously, we're having to go off history. And so trying to get as much information about what happened when they took that antibiotic, what was the exact reaction. Fortunately, there's been a score that has been validated to kind of screen penicillin allergies, and it's called PenFast. And the acronym essentially stands for the questions that you ask patients to screen the severity of their allergy. So asking if it's been 5 years or less since they had this allergic reaction, because we know that these IgE-sensitive reactions kind of wane over time without exposure. Was the reaction anaphylaxis or angioedema? So again, was it a true hypersensitivity reaction? Did they require intervention for treatment, mainly epinephrine, to resolve the reaction? So if you only get 0 to 2 points on the scoring system, it's really low, and I'm willing to challenge you as a clinician. If it's 3 to 5, it may be worth more of a shared decision-making conversation or taking a deeper dive into the agent and what antibiotics may have lower cross-reactivity to treat you with.
I like that is a very easy thing to do. Where can people find that score?
Yeah, I think if you just Google it, it's going to come up for you. I mean, thanks to AI, everything comes up if you just Google it now. But there is a very recent validated trial that kind of succinctly goes through where this was validated, I believe, in Australia, and then we kind of have whittled it down. And so our own institution, at Davis, it's part of our penicillin allergy pathways to use this. But if you just search it on the internet, PenFast, PEN fast, it should come up for you.
Fantastic. And is this a feasible thing for us to tackle in the emergency department? Can we delabel people? Do you delabel people? Or do we need to send them to an allergist to make that happen?
Yeah, so it's really interesting. At Duke Hospital, they published some literature where they had kind of pharmacists go through a desensitization questionnaire for patients that were started on aztreonam. And they found it very successful. I think roughly 90% of people were able to be started on a medication within the class that they were previously allergic to. So I think, for us asking these simple questions, if someone can give me a good history, of course, it's very easy to go through this delabeling process. And I also think to keep in mind is like us for clinicians, we don't necessarily have to totally debunk the allergy as in remove it from their chart. But if you collect some information and you feel pretty good that the penicillin allergy was 10 years ago, and today I'm going to prescribe a third-generation cephalosporin to treat a pneumonia or urinary tract infection, and the patient tolerates that in your ED, feel free to add that to their allergy. Tolerated ceftriaxone November 2025. And then in future iterations, we can potentially continue to make some treatment decisions and test kind of the boundaries of this allergy based off the fact that they have tolerated other medications in the past.
So, Haley, remind us, what are the differences between IgE-mediated hypersensitivity reactions and delayed hypersensitivity reactions to penicillin? And how do these distinctions influence our clinical decisions in the ED?
Yeah, so the IgE-mediated are going to be the classic allergic reaction symptoms that we all fear and think about. So anaphylaxis, angioedema, urticaria, kind of wheezing, dyspnea, those multi-system signs that someone's having a true IgE-mediated reaction. Some of these delayed hypersensitivity reactions are going to be things that patients experience 6 hours or more after administration of that medication. And so these are going to be more IgG or IgM mediated. There are some severe reactions, like if patients present with ulcers on mucous membranes or skin desquamation consistent with like SJS or some other of those classical, skin life-threatening conditions. And there's kind of like a triad of having a fever, an urticarial rash, and arthritis that's described as serum sickness. So those are going to be more severe delayed hypersensitivity. But I think the one that we're very common with for patients in the emergency department is just a plain rash that's not hives or urticaria. And so that's well documented, and kind of our allergy and immunology colleagues have put out some guidance to say it's okay to treat through for patients that just kind of have this rash that doesn't get worse if they're on the most appropriate antibiotic therapy for that infection.
So Jules, talk to me about a mox rash in kids. I know this is something you see. Do you count this as an allergy? How do you label this?
Oh, God, Sarah, we see it so often. So actually, no, I do not count it as an allergy. There is a well-documented phenomena that certain viruses plus amoxicillin create this diffuse rash that scares a lot of family members. And it's annoying. I have kids that have had rashes, and you walking through the stores, you get stared at. So I understand. But it is just a normal phenomena. I definitely do not label someone as penicillin allergic if they get a rash after having had amoxicillin.
Yeah, and one of the things for me is that the rash from amoxicillin and that viral combination usually happens like at least 3 days later, sometimes like 7 to 10 days later, as opposed to like an immediate reaction, more of an anaphylactic kind of rash or urticarial that would happen pretty soon after taking that medication.
Right, and I think the key word that you also said is urticarial as well. While the rash from amoxicillin can be urticarial delayed, it is not that usual urticarial rash that you get with that initial allergy. Okay, let's go back to doing this in the emergency department. You said the pharmacist have that ability. Do you need to be a pharmacist to delabel? And do you have to do a trial in the ED? Kind of like walk me through, what does that on a practical level look like to delabel somebody?
You don't have to be a pharmacist. I think anyone can collect a pretty good patient history. It's actually a really good space to empower kind of med students to do it too when they're in the ED.
Yes, I have done that.
Yes, they should be very comfortable having these conversations because, like you said, it's so prevalent and it's not something to be afraid of. So I think training each other and being very comfortable with asking those questions, I think how much time has passed since having that is going to be your first one. And then really what the reaction is. And I think you guys, especially as physicians, can ask some follow-up questions about, did you have to take something to make it better as like that third and final follow-up question. And I think asking those 3 questions should give you a pretty good picture of whether you feel like this was a severe allergy, maybe not to be challenged, or this is something that I could probably delabel in their chart, or if you can't delabel it, really clarify, because I think a lot of times the documentation for allergies and chart is just like unknown. So if you're able to get some more information, even just adding that into the chart and putting that in can help people make decisions in the future.
And take something for it. Does that include Benadryl? Because I feel like everybody takes Benadryl when they have a rash.
So the PenFast score specifically says epinephrine, I think because of those scenarios. But I think for us, if I'm collecting it, if they had to take Benadryl multiple times, that may be suggestive of a more persistent kind of reaction, maybe related to the medication if they continue to take the medication. But Benadryl alone, I would probably not put a lot of weight into considering it as a more severe reaction.
So your score is 1 or 2. Do you do an oral challenge in the emergency department?
Yeah, I think it's reasonable if that's the antibiotic that you want to send them out on. So let's say amoxicillin for an ear infection. I think it's totally reasonable to give them the first dose in the ED. Do your 30 minutes of monitoring for when that reaction should occur if they're going to, and then we can safely delabel that allergy.
Sarah, Haley, I'd like to hear from both of you guys. What do you see are some of the barriers to doing this in the emergency department?
I think it can be really difficult for people who maybe don't know the name of the antibiotic that they took. I think now with cephalosporins, there's about 1 billion antibiotics that start with C that are really hard to pronounce. And so I think that can be really challenging if patients don't know and maybe I can't see their fill history to kind of elucidate further. So I think if they can't give me a good history, obviously that's very challenging. I also think sometimes we experience this in the ED. They may tell one clinician one thing and then I may go talk to them. They may say something slightly different. And so then that makes me a little questionable about maybe it was a severe reaction and they just kind of weren't thinking about it in the time that maybe, you guys were doing their initial history and presentation and trying to get a lot of information at once. So I think those are 2 things that I find challenging as a clinical pharmacist.
Yeah, I think time and risk are also factors. So, first of all, the ED is always a busy place. We are going through patients really quickly. We may not have time to sit down and have that talk. And even if I have that talk, if I'm a little bit unsure about what their actual risk is, there's a very real medical legal threat that we feel in terms of if I do give this to them and then they have anaphylaxis, then I'm in big trouble. And so sometimes it's just easier to say like, okay, they think they have an allergy. I'm not really sure. I'm going to go to this next step. It's awesome at RED because we do have clinical pharmacists and you guys come in and talk to our patients and have some of these discussions. And then I also feel a lot more comfortable if we've all discussed it and like, well, the pharmacist thinks this is okay. I think it's pretty much okay. Now we can kind of, try the medication and see how the patient does.
Yeah, I agree. Those are some of the things that I run into as well is like the easy thing to do is just be like, okay, next med, moving on, because we do have those choices. It's just when you really sit down and look at all of the downsides of that easy choice, like these are very real risks. And I am just as guilty as the next person of taking the easy route. Don't get me wrong. It's just as I've been thinking about this and looking at this more that I'm like, man, this really is an important thing that we all need to be a part of. And I do think primary care doctors need to be a part of that discussion as well. This isn't just an ED thing. But one of the advantages we have in the emergency department is we can give meds and do a trial and watch. It's not great for our throughput time, but you can watch them. And nobody is better suited to take care of an allergic reaction than we are. And so in those senses, we are a little bit more uniquely advantaged to be that person to have that because we do have the Haleys in the world. And we do have our epinephrines immediately available and our airway experts and all of the things that need to be in place. So I think it's helpful to think about the things that we have in our advantage as well.
So let's talk about cross-reactivity between penicillins and cephalosporins. This is something that always comes up because the EMR flags me when I want to give a cephalosporin because of a maybe prior amoxicillin allergy. So what is the current evidence here?
Yeah, we have pretty great evidence kind of saying that cross-reactivity for a beta-lactam class depends on that R1 side chain. So later generation cephalosporins, like your third, fourth, fifth generation cephalosporin, things like ceftriaxone, cefepime, are going to have less than 1% cross-reactivity with penicillins or aminopenicillins like amoxicillin. We have pretty strong evidence to suggest that. There's definitely some funky ones that are actually not cross-reactive that you wouldn't suspect. But in general, the rule of thumb I always kind of guide clinicians towards is that later generation is likely going to be safer than things that are those earlier generations of cephalosporins.
Okay, that's it for penicillin allergy discussion today.
And I wish that was it for the penicillin allergy discussion in general, but I know that we're going to have to face this probably on my next shift.
It's true, Sarah, but hopefully now we will all have a framework for that discussion.
Thank you again to our department for having pharmacists in the ED with us.
And thank you to OM Productions for being here for us.
So until next time, stay curious, stay inspired, and stay tuned.